Good morning. I'm Jill Nichols, and I'm going to be your first speaker for today. We have three total guest speakers in your first panel, and we're going to talk about it's not just savings, but how telehealth, case management, and the PPOs, how they all contribute to the quickest and best return to work program for injured workers. We're going to start off with the PPO, work comp networks. Next slide, please. As you can see here, we have several key members who each play vital roles to ensure our networks are working at optimal levels. Our solutions team consists of both national leaders and combined with the local experts. The national team members are listed on the top row. They are the ones to ensure that CorVel's operational directives are delivered to the field and that our best practices are consistent all across the nation. This team is a huge support to the field for analytical reporting and ensuring processes and procedures are being followed. They are a great group of very highly intelligent people that I'm honored to work with on a regular basis. By having these national people, the national developer, for example, Deanna Kaufman, we can actually negotiate contracts with providers who have exposure in several states into just one agreement. This is a benefit because we can leverage the nation as a whole in its entirety for deeper discounts for our clients, and is also the most effective and efficient way to reach a large group of providers all across the nation. Our local developers have local expertise and they dial in to understand their specific state rules. For the sake of today's call, you're going to see only here on the lower section, the Sunbelt region. This is my group, and we have groups like this all across the country. I'm a local network manager for the Sunbelt region. Our local developers are required to understand market areas and have a key responsibility for recruiting and negotiating contracts within our specific territories. We also oversee submitting the credentialing and re-credentialing documents to our credentialing experts, and we identify the customer-specific needs in our state. Many of us manage specialized programs, MCOs like the Oklahoma CWMP, the Texas HCN. Next slide. For today's call, there's a few takeaways that I would like for you to focus on and remember. What we're going to talk about is CorVel's network offering. How do we locate providers in the network? And what is CareIQ? And remember, if you have any questions at any time, to feel free to use the Q&A chat pane. To better help understand why networks are so important, we want to share a report card that is put out by TDI. This is the only report card put out by any commission in any state, so we wanted to share this one with you today. Each year, CorVel, we submit data for the state to review on our MCO program in Texas, also known as the HCN. You'll hear the HCN more and more popular every day. The overall goal of the program is to have the lowest cost of claims with the quickest return to work with the highest mental and physical functioning scores possible. There's a lot of dynamics at play to try to get this result. As you can see on this slide, CorVel has the lowest overall medical cost per claim than any other competitor in Texas last year. And this is big for our customers, and it's a huge representation of what we do as a team as a whole here at CorVel. So this is something we're really proud of, and we work really hard every day to continue with this path. Next slide. In the report card, here's some key highlights, some things to really identify. We, as CorVel, were able to actually reduce our physician cost by 44% over a 4-year period. This shows that there's a strong claims handling, coordination with case management, quick access to care using our telemedicine products. Of course, this also represents in-depth bill review, UR follow-through, PPO contracting and credentialing. These are all required components of an MCO program, and they work together phenomenally to produce this outcome. Each component is extremely important to make this result happen. They work together transparently in the same direction to reduce these costs. Also, another key highlight is CorVel uses hospitals half as much as any network in Texas. This is huge. By channeling patients to physicians rather than them ending up in the ER, that's a key factor in reducing overall cost. And we return patients back to work in our HCM program twice as fast as any other network. And by managing our claims and using all these HCN rules and guidelines created in Texas, we are able to get our patients back to work a lot faster. You might be asking, what are the differences? This is something I get pretty often between a network, a PPO, an NCO, a lot of similar acronyms. In essence, for the sake of CorVel, these are actually almost all the same thing. In general, a network is a group of providers that make referrals to each other based on specialty. A PPO, which is a provider organization, it is a group of medical providers that all contract with companies like CorVel to provide services at pre-negotiated rates. They help our clients control cost and provide protection against overbilling or prevalent billing issues. Now, an MCO, which is the HCNs of the world, the CWMPs in Oklahoma, and we have them in several states throughout CorVel. This is more than just a panel of providers. MCO is a managed care organization. It's an entire program. It's typically regulated by a state and certified. They contain things like credentialing standards, quality improvement programs, medical director oversight, UR, case management, bill review. It's just a lot of different things working together. And each state has their own requirements of what each work plan may offer. CorVel owns our own national network. It is comprised of over 750,000 providers. All providers' demographic information is stored and maintained within our CorVel's national database known as the NDB. The NDB is linked and accessible for locating physicians using our online directory, and we'll go over the directory shortly. In this directory, a user can sort by specialty, distance, whatever the access to care need is at that time. It's not locked. It's open and available to anyone to access anytime online on our website. By owning our own network of providers, this allows us full visibility into our work comp claims and more control to manage and customize our networks to meet the needs of our clients. We have full transparency by being able to run utilization reports and bill history reports. We can see which providers are treating which patients and be able to identify any area of opportunity to see which providers we want to recruit, which ones we want to non-renew, things of that nature. And as you can see here on this slide, this is just a screenshot into our task management system. This task management system is to handle our contracting and credentialing efforts to show transparency between all the different parties and employees that work together to execute agreements and credentialing. Each provider, as far as credentialing is the next topic, each provider is thoroughly evaluated before they're ever brought into our network, and then we re-credential them every 3 years. So our credentialing program does a stellar job to ensure we maintain excellence in our credentialing practices. For example, our current provider manual has about 64 pages long. It's a lot of information to ensure that our providers are following credentialing standards before we even bring them into our network. Also, this system tracks our contracting, helps us identify which providers we want to go after in order to keep our clients updated of any nominations that we receive, whether it be from an adjuster, a case manager, from anyone out in the field. Our contracting developers are the ones that are required to recruit providers and use this database in order to monitor and track those nominations process and credentialing practices. It just allows us to seamlessly work together as a company and work with our national folks as well. So it's all brought together by one incredible system. Okay, so now I'm going to show you an example of our online directory. I'm going to jump out here and try to go to our directory. Okay, so I'm going to share my screen here. When you go to Corvell's online PPO lookup, you can search for a physician by hitting the search option. Across the country, the first auto default for the network option is workers' comp. This will be your auto default for any state that may not have a specific narrowed down network. For example, if you wanted to search by different states, if you select the network drop-down field, you'll see various options here. I'm going to pick an example to show you how the directory works, so you can feel free to play with this tool anytime you want. We're going to look at the Texas Work Comp Certified Network for an example. You can search by radius by looking at 30-mile distance if you want. This toggle will move you between different radius searches. One of my favorite features is actually to look at the state level, and I can look at Texas as a whole. If I hit this gray bar here for search field options, it's going to drop down and allow me the ability to search by tax ID or provider name. One of the best is just the less you put in, the less that's going to limit you down to what's going to print out in the directory. So I'm going to search by a doctor named Rafa and see what comes up if I just select his name. If you scroll down and hit search, I'm only selecting by Dr. Rafa in the whole state of Texas. And as you can see here, his information showed. One of the biggest important factors is to note you should always just hit the back button to get you back to the main screen and start fresh. By refreshing each time, it allows you the ability to not have too many parameters or details accidentally interrupting your search options. So this is available for you to play with at any time and get familiar with, to be able to identify providers within the PPO options. Okay.
Jill, you're ready for me to take it back, right?
Yes, please.
Okay. Just a moment while I share the presentation again. And away we go.
Okay, you can go to the next slide.
There you go.
Ancillary services. This has been a really big topic that is growing at an astronomical rate. Ancillary services, they average about 48% of today's current medical spend. There's no doubt they represent a big opportunity for cost savings. Fortunately, Corvell, we have a CareIQ product to assist with managing these costs. They have ancillary services for PT, imaging, DME, home health services, also transportation and translation. CareIQ is designed to help all parties with coordinating process. They help facilitate the claim along. They help monitor utilization to ensure providers are not overusing services that are not necessary. The CareIQ, they work with our UR team to get authorization to ensure the requests that are happening are actually indeed medically necessary. CareIQ also offers deeper discounts than a traditional PPO contract because they actually bill on behalf of the provider to reduce billing issues. Basically, CareIQ manages the entire coordination of care from appointment scheduling all the way down to reimbursement. By doing this, we're able to achieve timely recovery and in turn increases the savings on a claim. And next slide. So to recap today, we talked about our proprietary network and what CoreVault offers. We talked about credentialing, contracting, we talked about how to use our directory, and we talked about our CareIQ product. So as mentioned, this panel is not just about savings. We've discussed the PPO. Now I would like to introduce Dave Lupinski, who will provide us with the ever-growing world of telemedicine.
Jill, before we
good.
jump over to David, we did get a question. And I think we'll take this question before we go on because it was, I think, relating to your presentation. How does CoreVault make sure that right from the beginning, the injured worker doesn't use an out-of-network provider?
Okay, that's a great question. There's several different ways to ensure that the patient does not go out in network. Each state has different protocols and parameters. For example, in the state of Texas, the patients are giving packets at the time of injury and at the time of rolling out the program to ensure they are aware they are supposed to pick an in-network doctor. They are not following the statutes and rules. We have 24/7, which is a hotline that it can be called that, depending on which account is signed up for it, that looks at our PPO directory to ensure when they're talking to a patient about their claim that they refer them to a network provider. So there's several different education opportunities with the injured worker to ensure they're going to a network physician. So we all play a dual responsibility to ensure that occurs: the employer, the employee, the adjuster, and account management to make sure those things happen.
Okay, thank you, Jill. So I think we're ready to continue, and I'll pass it off to David Lupinski.
Sounds good. Thank you, Matt. Good transition, talking about advocacy, triage, and telehealth. And I know we're all sick of hearing about the pandemic. I do think telehealth is going to be one of those silver linings of the pandemic. So we're going to talk a little bit about, what kind of, how it fostered the growth of telehealth and kind of where telehealth has come from and where we see it going. So we'll go next slide. I think it's always interesting just for any service or any technology to kind of look at the genesis of it, where it started and what problem they were solving. So for telehealth, it actually started with NASA, and the goal was to bring healthcare to places they don't have it. Even with Elon Musk today, they don't have urgent cares in space. So maybe someday, but today you need telehealth. And telehealth really for the next 40 years, this was the 1960s that NASA was looking at it, kind of kept with that same idea of bringing healthcare to areas that didn't have it. So it really focused on the rural communities and bringing specialties to that area that maybe didn't exist there. And then over the course of the last 5 years, we really started to see telehealth grow into the mainstream. But like any technology, there kind of has to be this converging of events. And so there was multiple things that happened in order to really facilitate the takeoff of telehealth. So the first was we needed records to be taken online. And this really happened with the Affordable Care Act and a big push for it. A lot of money came in to support electronic healthcare records. And we saw this big shift back in about 2014. If most of you probably are familiar, you go to your doctor's office now, instead of writing on a chart, they're typing on their computer and they're working on what's called electronic healthcare records. And this was essential. There's no way telehealth could be done if it was still records are being done on paper charts. The next piece that the converging technology, and this is, again, we can even see it in here, the last person looking at their phone, is we needed mobile technology. So if we're going to bring healthcare to patients virtually, we needed some medium for which they could, do the visit and see the patient. And today it's 85% of Americans have a smartphone. So that really helped set up us for success in the growth of telehealth. And then the last hurdle that we really saw was we needed regulatory support. So was it allowed at the level of the state medical board? And so with that, let's go to the next slide. Let's look how that landscape really shifted quickly. So this is 2013. This graph is looking at states that allowed telehealth without a prior in-person relationship. So you could do your first visit with the telehealth provider. And as you can see there, it's about half. The landscape was mixed on it back in 2013. We'll go next slide. We can see some shifts here, and we'll go through these pretty quick. In 2014, landscape is shifting. Go next slide, Matt. In 2016, if you aren't aware, Texas was one of the last states to adopt it. They actually were in a lawsuit with Teladoc, was one of the first publicly traded telehealth companies. But following that being solved, we can go to next slide. And yay, it was about the end of 2018, where it all green, where we had allowances at the state medical board. So for many of us, Corvell had started telehealth in 2015. We thought, wow, this is the tipping point. We have allowances across the country. We've got everybody with mobile phones. All the records are already online. So we should hit that tipping point and see a big explosion. And we'll go next slide. We really didn't. We did see a big uptake. A lot of the health plans on the group health side were definitely promoting it. It was being offered. It wasn't a huge uptick in terms of utilization. And so if any of you are familiar with change is hard. Change management is hard, especially with a big healthcare system. And we would have these healthcare systems where their CEOs were touting, we're going to do 50% of visits through telehealth on that are done through outpatient. And the physicians were just not changing. And so it was a difficult thing. They said, look, we're already having success with our current model. We don't want to change. It's the pain of changing. What if they can't connect and da-da-da-da. And we just were having a lot of roadblocks in terms of getting the uptick. And that's really what COVID did for us. It created enough pain to where patients just were really saying we need to be seen in this medium. There was a fear about exposure to COVID and wanting to be seen virtually. And that really forced the providers to change their behavior. And our partner for telehealth, American Well, saw almost a 20,000% increase in the usage. And so pretty amazing of how many patients were seen in this medium, how the usage was done. And really to us, what we're thinking now is the toothpaste is out of the tube. It's gonna be tough to get it back in. Patients are amenable to this, providers are amenable to this, and we'll talk about some of the success that we've seen from it. So we'll go next slide. Before I just kind of want to show you just graphically how the landscape changed for us. So as you can see here, and again, Carly or Jill mentioned about how we start with triage and cases that come in for us. So this is for Corvell, 70% of our claims start with nurse triage, determining the level of care and what would be appropriate for that patient. And we would see that, 43% would be self-care. They could be handled with some self-management. And then we would see about 10% telehealth. So we had about 50% that were being handled virtually, but prior to COVID. We'll go next slide. Post-COVID, we can see a big change here. And just patients were just so much more amenable. We always offered telehealth as an option. We had people requesting telehealth. So we saw a huge jump here where it was almost 75% were being treated virtually. So a huge change in the landscape in terms of where patients were being seen. And we're seeing this on the group health side too. It's just a shift of where is care going to be seen and handled most. I think some pharmacies are betting it's going to be handled there. We're seeing a lot of the health systems adopting because we are going to see a large portion of care being handled at home. And go next slide. And again, just reiterating the 74%, so how much is being handled virtually? And we'll go next slide. So what does that mean for the employer? So I want to go through kind of the benefits. Obviously with COVID, we had the avoiding, the potential contamination, but there's so many other benefits to telehealth. So I want to highlight a few of the metrics that we have up here. The first is really productivity, and we'll highlight this is the benefit of telehealth and the shift in medicine of being able to bring healthcare to the patient versus taking the patient to healthcare. And so in the typical model where you're going to the brick and mortar setting, the average travel time is 20 minutes. You have a wait time of 2 hours. A time away, at least looking at evidence-based studies, this varies by jurisdiction and by location, is about 4 hours of a wait time. And with telehealth, it was 30 minutes. So this is a big shift for employers of just keeping your employees at work, being able to bring healthcare to them, modify some duties, get them the medicine that they need, and being able to keep them working at the job. That's a big change there. The next change I want to talk about is just the prescribing habits. And we can see narcotics in telehealth, they are loosening up the regs with regards to controlled substances. For our practice site and the type of patients that we see, we don't feel that that's appropriate. So we'll always be at 0. So there are a reduction in terms of controlled substances and what they could get in the brick and mortar setting. Medications we see less. Where you really start to see a difference is where brick and mortar providers have a vested interest. There's a financial interest. So obviously providers that own x-ray machines do more x-rays, not too surprising. We see DME, especially when they're dispensing from their clinic, going significantly up. So significant changes there in terms of the prescribing habits. And then the last place that I want to highlight, and this is really what we're most proud of, is the patient satisfaction. But before I go into that, we'll do one more click, Matt. Spinning. Yeah, and so what we saw was a 60% reduction for medical expenses, just based on not looking at unit cost, but just based on changing the prescribing habits. And like Jill said, we see the ancillary benefits really being a large driver of care. And so by reducing the need for those, and again, it's not to say that we're not ever using them, but taking away some of those financial incentives made a huge difference in terms of the cost of the total episode of care. So patient satisfaction. So how did we measure that? Let's go next slide. Probably most of you have seen this with an app that you've used. You close out of the app and it asks you to star rank it. And the same thing happens for us in telehealth. So we get star ranked. Our app is Corvell Telehealth, if you want to look at it. We actually have a star ranking right now of 4.8. And anyone that ranks it below a 3, we actually get alerted to that, and we will go and investigate and see if there's an opportunity to improve or to reach out to the patient and make sure that everything was done correctly. But really something we're excited about. I think with managed care in general, it gets the perception that it just comes with some baked in adversarial friction. Formularies, it could be perceived as like taking a medicine I'm entitled to, or could be taking a benefit. And this is something where it's not that I have to do telehealth, it's I get to. And it's really great to see that it's not just having benefits for the payers in terms of reduction in cost, but really benefits for the patients in terms of bringing healthcare to them, making it convenient, and just having high satisfaction scores with the care that they're getting. So we'll go next slide. Let me take it out of the esoteric a little bit. I just want to walk you through an example case. So this is a real case. We've all probably experienced something like this with a lumbar sprain, pretty common for us. Called the nurse first to determine level of care. Our average speed of answer is 30 seconds. We were 3 seconds in this case. Got them over to telehealth. Everything's connected through web services. So as soon as the nurse has completed their charting, they click a button, all the data flows electronically to our telehealth provider. They were able to see the patient within 2 minutes. You can see they did some initial work restrictions, provided some lightweight medications, some non-steroidals, a non-narcotic muscle relaxer, did a follow-up visit. Again, this is highlighting here that we don't necessarily need to knee-jerk with physical therapy. So second visit was 9 minutes to get into the visit, just modified the work restrictions. You can see they're lifting up to 25 pounds now versus 10. And then the third visit was only 3 minutes to get there, and they were full duty release, no impairment. And so Matt, let's do one more click. And some of the takeaway on this one, this was under 14 minutes for the total episode of care in terms of wait time. So really convenient for the patients. We get to meet them where they are, and you can really provide high quality care through this medium. So exciting for payers, exciting for patients. We'll go next slide. So last piece, I just want to talk about where we're going. So we've seen some exciting things at intake, and we're seeing some exciting things with just digital health in general in the healthcare space. And Apple, being the disruptor it is really pushing some of this forward. They did something they called the Apple Heart Study. If any of you have an Apple Watch, hopefully you haven't seen this, but it's actually looking for arrhythmias. And what Apple really wanted to do was to shift the model of care. So we say we have health care, but we really have sick care in the sense of most patients just go to the doctor when they're sick. But what can we do to keep people healthy? And so what Apple was looking to do was attack a disease study called atrial fibrillation. And it's really a silent killer. It doesn't get seen very often. You have to have an electrocardiogram while you're in AFib. So a lot of times people go in and out of it, and it just gets missed until people have a stroke or some type of significant condition. And so what they did with this is they have the Apple Watch. It's on you 24/7 for most people, or close to it. And it's tracking data. So it's looking at data that it's getting through the wearable. It's running that over AI. So it's looking for any kind of arrhythmias. And as it catches that arrhythmia, it'll actually push out a request to do a telehealth visit. So proactively, they can identify if you're at risk for AFib, and they could mitigate that risk through some type of medication. We thought, wow, that's super cool. That's what we want to do. And so we'll go next slide. So we wanted to follow that same path. We have data, we have AI, we have telehealth. So we wanted to look at how could we take all the data that we have. We have data with bills, we have data with pharmacy, we have data with the case managers, and how could we identify risk, and then could we push out telehealth to mitigate that risk? And really what we focused on here is the state of chronic pain or delayed recovery. So for psychosocial concerns and combination certain types that they might be taking, and really identifying risk, but not waiting for that risk to just manifest itself in a negative way, but really intervening. And the difference with this too, what you can do with telehealth, a lot of times you intervene by stopping what you don't need. So use opioids is a good example. We all know we had too many opioids, so we put up roadblocks for opioids. But then what? So now you have a patient that was at risk for delayed recovery that can't get opioids, but then what? Are they going to go more injections or a surgery? And so what we wanted to focus on is how do we push out telehealth to focus on what we do need? And so we'll transition here a little bit into bringing in Karen Thomas, and really what we do need on this, especially for the delayed recovery and the psychosocial concerns, is what we need is an interdisciplinary team. And with using telehealth, it makes it so much easier. We can bring in the physician, we can bring in our case managers, we can bring in people that really aren't geographically close, but we can have them all on a shared visit. So they can all be one communicating, sharing the same objectives, and really working in sync and in step with one another to make sure that we deliver the best outcomes for the patient. So with that, I'll turn it over to Karen Thomas to talk to you a little more about case management.
Awesome. Thank you, Dave, so much. Good afternoon, everyone. Thrilled to be with you this afternoon, this morning, depending on where you are. I am Karen Thomas, Corvell's Director of Case Management Innovation. I am a registered nurse. Can't believe it. I'll celebrate my 35th anniversary this spring of becoming an RN. So today I'm going to talk to you about case management, what it is, how it's unique here at Corvell, and what we're doing to overcome some of the challenges that have been thrown at us, particularly this last year with the pandemic. Next slide, please. So healthcare has become incredibly complex, right? So there is the technology that is now coming fast at all of us to deal with. Privacy, security concerns. The way that medicine is now practiced, very different than 5, 10, 15 years ago. So here in the United States, we're very specialty focused. If you or any of your loved ones have tangled with medicine and healthcare, you know that potentially you could have any number of providers that are overseeing your healthcare. So one that's looking at your heart, one that's dealing with your musculoskeletal issues, another perhaps an endocrinologist that's dealing with your diabetes. Maybe you have a pain specialist. So on it goes with this very fragmented approach. And that leads to some communication challenges, making sure that the left hand knows what the right is doing. Ensuring that all the providers are on the same page, connecting the dots. And on a good day, for any one of us to have to deal with this, super challenging. And in the work injury space, that is just compounded. Our approach in workers' compensation without really meaning to, we send a message to patients, hey, we're in control, we're going to tell you what to do. That causes a patient, an injured worker, to become somewhat passive in their approach in their own recovery and healthcare. And I know as a health professional, that's really going to undermine recovery and restoration of function. In the pandemic, all of these issues have become really magnified. So not only do we have the challenges that I've just talked you through, if we go to the next slide, Matt, we have some new things that have really bubbled up. And I know we're all kind of done with COVID-19 and wish it would just disappear, and it is. It is. Every day, the light is getting brighter at the end of the tunnel. But we are seeing trends that we're really going to have to deal with and are dealing with in healthcare in the months to come. So for sure, the way that we work and where we work has changed. We also are dealing with a lot of isolation, right? So we all had to kind of hunker down and isolate to avoid the virus. And it's known that social connection is really fundamental for the source of well-being and renewal. Humans need this. So this isolation has really magnified some mental health issues, depression, anxiety, agoraphobia, reluctance to kind of get out in public. These are coming to light. We know that mental health issues are the third most expensive health condition to have to grapple with. Number 3 only to cancer and heart disease. Statistics tell us that injured workers experience clinically related depressive symptoms at some point. That's 50%. And they're most vulnerable the first 3 months of the injury. So very important that we are addressing injured workers holistically. We have to address the body, mind, soul in order to achieve full recovery. And again, restore that function. Of course, we want them back to work. Very, very important. That goes hand in hand with that full recovery philosophy. Another trend that we're seeing is certainly a lack of commitment to the upkeep of overall health. So there's been a reluctance to get out there and get basic screening done, understandably. People as a whole are really concerned about contracting and exposing to COVID virus. So, you know, basic scans, mammograms, colonoscopies. These have been greatly reduced over the last year. So there's going to be, we're now seeing that there's going to have to be a real catch up to get these basic health functions taken care of and addressed. And that's going to affect recovery from work injury, work illness. So, you know, although those basic health needs are not a requirement or going to be covered under the work injury, they are going to affect that recovery for sure. Another disturbing trend is the use of alcohol, recreational drugs. So while folks have been stressed and perhaps bored, seeing a 54% increase in purchasing of alcohol across the country, 14% increase in use, and a really disturbing statistic, 41% increase in binge and heavy drinking in women. So just think about that, 41%. Prolonged stress. So, you know, that drinking, recreational drug use certainly tied to the stress that everyone has been under, not just episodically, but over greater than a year. So when we're exposed to that type of long-term kind of issue, we know that it's going to lead to burnout. You're going to be hearing a lot about this in the coming months. So prolonged stress has a definite effect on the brain, can cause some cognitive issues that are certainly overcomable, but they're going to affect focus, memory, and as people have been dealing with kids at home, they're also having to care for aged parents, doing homeschool. Dynamics have changed in relationships as we're all living together under close quarters. All of these things do directly affect our workers and their response to injury and illness. So finally, work environment. What does that look like in 2021? How we work, as I mentioned, where we're working, the stress that our frontline workers are having to deal with going into grocery stores, offices, healthcare workers. So dealing with the stress every day of being exposed to the virus, keeping themselves safe. We're seeing an uptick in workers who have been sent home, who perhaps don't have the best ergonomic setup at home. All of these things we have to deal with again as a team. We have to collaborate and make sure that they're all addressed. New diagnosis that has popped up, post-COVID traumatic stress syndrome. So, the positive is we're getting vaccinated. We're going to be able to return to the workplace in many instances, but there's going to be a lot of anxiety that workers are going to have about coming back into that environment. As employers, as healthcare workers, we all are going to have to get behind and supporting that and helping that transition. So kind of a bleak picture, right? But if we go to the next slide, I'm here to offer you some optimism, some sunshine, because we definitely have a solution for you, and that would be case management. So what is case management? There are different flavors of this, so I'm going to speak to you specifically about medical case management. These are advanced practice nurses that assist with healthcare navigation. And they are literally tasked to identify and solve for obstacles that are in the way of recovery, return to work, ultimately restoration of function. And these nurses, they use their clinical experience to leverage the knowledge of local resources to assess patients. So they are connecting the dots in that fragmented care, making sure that all of the providers are speaking to each other. They have that big picture view. They literally drive collaboration on the team, not just with the healthcare providers, but with the claim professionals. They also are making sure that we are driving into the PPO. So Victoria had asked earlier, how are we doing that? Jill did a great job of speaking to the shared ownership on the team. When a nurse case manager is on a file or assigned early on, as is the case with Dave's nurses on the 24/7 advocacy team, we're making sure that we're penetrating that PPO, achieving that quality care, and making sure that we're doing it in a cost-effective manner. They also help connect the dots with pharmacy programs, really, again, have that big picture. And most importantly, nurse case managers act as patient advocates. So they really are patient first. They want to be sure that the injured worker, and I'm using that interchangeably because I just can't help myself as a nurse, patient, injured worker. They're making sure that all the questions are answered, that injured worker is engaged in their own care and recovery. They're assuming some responsibility for their own destiny and their own return to work. And all the while, nurses are driven by science. So they use evidence-based guidelines to help them keep an eye on really what the science and data tell us about best treatment and when we should really be expecting the return to work. They hold the medical team responsible to those guidelines so that we are marching towards continuous improvement in function and getting these people back to where they need to be. Next slide, please. So we know last year there were over 3 million non-fatal work injuries. 50% of those injured workers experienced lost time. And of those 50%, we know that another 50% are going to be out of work greater than 12 months. Now, here's what's really concerning. When an injured worker is out of work longer than 12 months, only 5% of those injured workers are going to return. That means the clock is ticking, right? So we only have a limited amount of time to really affect the trajectory of the claim. We know that case management is ranked #1 as having the greatest impact in medical management programs. So certainly nurse triage, that is right behind case management. So having these nurses very early on the files is what is going to change the whole effect of that claim. Case management is offered in a variety of, I'll say, flavors. So first we have telephonic case management where the nurses are just, as the descriptor tells you, intervening telephonically. So they are connecting with injured workers, employers, providers, the claim professionally through telephonic interaction. Last year, overall, Corval advocated for over 50,000 workers, and we saved our customers $382 million, right? So very significant effect that these nurses have. And the return on investment, typically for telephonic case managers, 7-to-1. So big impact here. They're all about developing those relationships, providing solutions, and making sure, again, that they're acting in that patient advocate role. Next slide, please, Matt. All of our case managers, whether they are telephonic or field, are now connecting with our injured workers virtually. This was kind of a silver lining. Dave mentioned have to look for the positives here with the pandemic. As a company that's very committed to technology, we were already in this space prior to last February, but we really leverage the use of those virtual visits. We can do that in very rural areas. The amazing thing about the virtual connections is how very personable they are. So to be face-to-face, one-on-one with a patient, really, making that eye contact, it can be very different, a very different experience than maybe marching into a clinic and having somebody kind of come and go in the room. This is where the focus is really on the patient. And we find that that connection has big impact on driving that patient kind of perspective and responsibility. Certainly our nurses are attending telehealth visits. So throughout the pandemic, they were able to have a presence, both with our own telehealth program and with the telehealth connections that physicians were rapidly scrambling to develop throughout the year. Our approach is really kind of a concierge. Nurses have had to become help desks, helping injured workers understand how to use the technology, how to actually make the connections. So we become very savvy at overcoming a lot of the obstacles that sometimes patients have to make the connections. Next slide, please. Field case management is certainly another flavor of case management. This is where our nurses actually are on site. So they're attending the appointments, they are doing home assessments, they're showing up at hospitals. This type of case management can be used episodically. So maybe we just need a nurse to go on one appointment, have a conversation with a physician, drive that return to work, or maybe get some clarification on the treatment plan. Or we're assigning them somewhat long term for the more severe injuries. We certainly, both with telephonic and field case management, we have nurses that are bilingual. Very important that we're able to communicate with injured workers in their own languages. So a variety of languages, we're able to do that. We have nurses that specialize in catastrophic injuries. So they're driving very complicated injuries and claims. They're experts and centers of excellence. They are certainly certified in this specific type of case management. We have 700 nurses across the country that are boots on the ground, able to connect with their particular resources. So they're a great way to tap in to make sure, again, that we're driving that quality care, but in the most cost-effective way. You see that in each of these slides, the nurses have a tablet or computer. So again, Corvell is very married to driving advances in technology. We want to make sure that we're using the technology for the betterment of our nursing practice. And as nurses are entering data, we have our proprietary system has the ability to develop AI, artificial intelligence, and then we've got predictive modeling in place that we're constantly developing, constantly adding to really help the claims specialists and our clinical teams identify issues before they become issues. Really key to being proactive in the workers' compensation claims space. So on the next slide, I'm going to point out one, again, silver lining that we're enjoying from COVID. So we've been able to provide some tools to our nurses. One of them with our business partner PureWell is an app that we're able to provide to injured workers who are perhaps facing a musculoskeletal surgical procedure. So PureWell offers a program where we actually help the injured worker prehab, get ready for surgery so they're in the best possible shape before they actually have the procedure. As COVID has disrupted surgeries, this has been just a huge game saver. So rather than having an injured worker sit back, wait, perhaps, Netflix, eat a bag of Cheetos every night. Now we've got an app where we can be driving. They're vested in their own kind of preparation. So the app addresses a couple of pillars of health. So conditioning, exercise, physical therapy exercises. So patients are able to learn their post-surgical rehab plan before they're in any surgical pain. This helps really allay the stress of the unknown. The app also addresses nutritional information. So we actually have people losing weight before surgery, which is so important when you're undergoing back surgery or joint replacement. Provides patient education on the procedure. Also helps assess home environment. So helping people get ready for when they come home from the hospital. Making sure that it's safe. We've got rugs up from the floor. We've addressed how we're going to get up and down steps. And then finally, pain and anxiety. So teaching people mindfulness, how to minimize the use of narcotic post-surgery. we use this app in conjunction with nursing, and the nurses are able to view a dashboard. They're able to see how the injured worker is interacting with the app. And then they're also able to identify issues that maybe are going to prevent or delay recovery. So again, huge, huge game changer. PureWell also offers a second program, which is a surgical avoidance program. So for very minor type of back pain or uh, um, other issues where we're trying to avoid expensive diagnostics or surgery, that's where PureWell can be a big help. So if we go to the next slide, this is just a little bit more about the PureWell app. We're seeing great results with return to work, decrease in TTD, overall decrease in medical spend, and decrease in physical therapy. So super excited to make this tool available to nurses and have our injured workers benefit from it. And the last slide just kind of walks through a scenario, a real life situation, grocery store worker who used nurse case management and the PureWell app. And you can see what the projected costs were and then what we realized by helping this injured worker prepare for surgery and be fighting fit when they went through the other side. So I want to thank everybody for your time today. I really appreciate the opportunity to talk to you about case management and how it is a game changer in the trajectory of workers' compensation claims, and also all the exciting things that we're doing to help our injured workers overcome their injuries and really realize full recovery.
Thank you very much, Karen, and thank you to our other panelists, Jill Nichols and David Lupinski. We do have some time for questions, I believe, before we go to the break. So I'd like to direct everyone to the Q&A pane. If you have a question for one of our panelists, please type it in there and they'll be happy to try and address any questions that you have. While we're waiting to see if any questions come in, I would like just take a moment to provide a little bit more introduction for our panelists. Jill Nichols is a provider network manager for Corvell. She's located in our Dallas office. Jill, how long have you been with Corvell?
HCN, for example, in Texas and other states within our region for a total of 13
Jill,
years.
I'm sorry to interrupt you, but you were muted for the first part of that. So let me ask you again, give us your bio. How long have you been with Corvell? And then you're going to tell us a little bit more after that, I think. Go ahead.
Sorry. Yeah, I've been with Corvell for 6 years. I've been managing MCO programs for the past 13 years.
Great. And David Lupinski is our Vice President of Digital Innovation. He's located in California in the Sacramento area. And David, can you tell us a little bit about yourself?
Yeah, thanks, Matt. I've been with Corvell. I think I'm coming up on 14 years. I've been in the industry for about 17 years. Really had a lot of experience with some of this just being an athlete, and I've kind of tried to take that model of trying to see injured workers as someone that wants to get back in the game and really giving them the tools to get back there.
Thank you, David. And Karen Thomas is our Director of Case Management Innovation. She's located in Virginia in the Washington, D.C. area. Karen, you did give us a little bit of a bio, but anything else you'd like to share about your trajectory with Corvell?
I've been with Corvell 20 years now, so obviously started as an intern, right? And worked in a variety of roles here at Corvell as a field case manager, managed the case management operation in Virginia and DC for a number of years, and then oversaw the 24/7 program until I came into my present role 4 years ago.
Great, thank you all. We did receive a question. This one's for David. What's the difference between telehealth and telemedicine?
Yeah, it's a little gray. We view telemedicine as like provider visits, Different states actually constitute what has to be a visit. So for example, if I texted my doctor, is that telemedicine? And so a lot of states at the level of the state medical board are now requiring that visits have all the same attributes of the in-person visit. So synchronous audio and video. Again, telephonic visits have been a question. But telehealth is kind of more the broader range of, it could include news triage, it could include remote patient monitoring, it can include texting, where telemedicine is more provider visits through the medium of telehealth.
Thank you, David. Another question for you. This is in regard to the slide that you showed with the reduction in ancillary services like X-rays, PT, DME, in telehealth versus in-office, and it seemed like a very large reduction to account just for services that are just rendered in the office versus or in the clinic versus not having it right there in the telehealth visit. Is there do you see any correspondence between using telehealth and being able to direct care into like our own Care IQ network? Is that a factor in the increase of utilization of telemedicine?
I think it's a decrease in utilization. I think the main decrease is really just taking away the financial incentives. We know some providers that have come to our clinic that said at their previous employer they were judged by revenue per patient. And so just taking away some of those metrics, obviously if PT's indicated or DME's indicated, we want it based on just patient and patient care and what evidence-based medicine says is most appropriate, not based on revenue per patient. And so when you take away the financial incentives, you just see that drop of how much they're using DME or PT or some of those other ancillary benefits that we've seen.
Thank you, David. Yeah, I misspoke. I said increase, but I meant decrease in utilization. Karen, a question for you. Could you tell us a little bit more about the partnership with PeerWell and a little more specifics about how do we identify and then refer someone into the PeerWell program?
So there are a variety of ways that we can identify patients. So and we work with our claims specialists to identify those. So we also can work directly with employers to identify and channel injured workers who are undergoing a musculoskeletal procedure. So that could be knee surgery, shoulder surgery, back surgery. As soon as we know that surgery is a trajectory, that's when we want to get them into the program. For those injured workers who we are working to avoid surgery, currently we're focused on backs. Here in Q2, it will include knees, and then Q3 will be shoulders. So the purpose of that program is to actually not only avoid surgery, but avoid unnecessary MRIs, CAT scans. So we're talking about very minor back sprains and strains currently. So any patient who's undergoing that certainly is a candidate for the PeerWell app and the nursing support that goes along with that.
And one more question about the PeerWell app. Do we offer this free of charge to customers, or is this something that customers would opt in on if they already have case management services through Corvell?
Yeah, it depends on the program, Matt. So in some instances, it's a package deal with the nursing. So I would encourage the audience to contact their account manager for more information.
Okay, thank you, Karen. Jill, we got a question for you about PPO recruitment. When Corvell considers providers to recruit into the network, how do we take into account like workers' compensation experience and provider ability to help facilitate a proactive return to work plan for our patients? Does that come into play as we recruit our providers?
Most certainly. A lot of the ways that we're able to identify the best providers in the community and in our market areas is I, as a PPO developer, am going to lean to our field for those doctors because I'm not working from a clinical aspect on a daily basis with the claims. The employers are hearing the noise, the adjusters, the case managers, and people actually working directly with the provider and patient on a daily, immediate relationship basis. So what we do is we actually like to hear that information so we can identify the providers that our clients are loving the most in the workers' comp arena. And sometimes just because you have a great satisfaction with a provider doesn't mean that they're actually the best provider. So then we go in and we take a look at the utilization of the provider and identify, is he or she being highly utilized based on quality of care, or is he or she being utilized because they are attorney driven but happen to have good response rates to clients, so the client may think that they're a great doctor. We take all of those aspects into consideration, and so we have a committee that is reviewing that information that comes from all various components of the clinical aspect with our medical director, our case management, with our case management nurses, our adjusters, things of that sort. So we take into consideration all the aspects that actually define whether a provider is a great work comp fit. So a lot of that is going to come from the outside world in to identify our patterns for recruitment and also our patterns for providers that we would like to non-renew or terminate from our network. So luckily we own our own network, so we're able to take that information and make things happen in regards to which providers we keep and which ones we choose not to.
Thank you, Jill. We have about 5 minutes left for this panel. We did get to the end of the Q&A. So if anyone else has any questions for our first group of panelists, please do type it into the Q&A and we will try and address it. Jill, was there anything that you wanted to say to draw this panel to a close?
Well, I want to thank all of the panelists for taking their time today to speak about these different topics, and anyone that had taken time out of their day to attend, as well as the people that chose to offer some questions. It was great to have everyone on this panel today.
Yeah, thank you. Let me echo that. Thank you, David, Karen, and Jill for your excellent presentations today. That's going to take us to the first break.